Hello and welcome. Thank you so much for joining us today. My name is Maria Judd and I am the Vice President of Strategic Initiatives and Engagement with a new organization, Healthcare Excellence Canada. And I'm really pleased to host our webinar, our conversation today, along with my fellow panelists who you'll see on the screen as part of Healthcare Excellence Canada's Spotlight series. We're focusing today on better care closer to home and how we build on the advances during COVID-19 of community paramedicine. I'm grateful to be joining this morning in my time zone from my home office in Ottawa on the unceded traditional land of the Algonquin people, where I'm really grateful to live, work, and play. And I want to welcome everyone who's joining us from across the country and invite you to introduce yourself using the chat feature in Zoom. Healthcare Excellence Canada's Spotlight series is a webinar series. It's really about connecting people to have meaningful and focused conversations about some of the most pressing issues facing healthcare across the country, and inviting people and hearing perspectives of those who are addressing those challenges and how collectively we can be working in new ways to organize, fund, and provide care with and for more people to shape the future of healthcare going forwards. And so thank you for your interest today in joining us, and a special thanks to each of our panel members who will introduce shortly. So as we know, paramedics across Canada work collaboratively with community partners and healthcare providers to ensure that patients receive high quality care and services closer to home and community. And we've seen during the last 2 years, and we've heard from people across the country, that is a priority for everyone in Canada. Care closer to home and community. And the COVID-19 pandemic and public health measures have really compelled changes to be made in how we deliver healthcare services, including paramedicine, and community paramedicine has really stepped up in new ways to better meet the needs of vulnerable populations and to leverage technology and to collaborate and coordinate care. And today we're taking a deep dive into the community paramedicine response to COVID-19, talking about what it's looked like, how it's evolved and grown and responded over the past 2 years, and what it can look like as we move forward, as we move through the pandemic, and as we start to look to shaping the future of healthcare delivery and care closer to home. Just a few housekeeping points before we dive in. We're really pleased to offer French simultaneous interpretation for this session. And if you'd like to hear the voice of the interpreter, please select French from the interpretation menu at the bottom of your screen. We do invite you to share your questions for the panelists in the question and answer feature from your Zoom toolbar, and the toolbar can be found at the bottom of your screen. We also invite you to add comments at any point using the chat feature in either French or English, and we encourage you to share resources and respond to comments in the chat as we move along. Do want to let folks know that this session is being recorded, and the recording will be made available to all registrants in the coming week, and it will be also posted on our website. And if you need support at any time during the webinar, you can reach out to our tech support using the chat feature. And now let's get our discussion started. I'm going to turn to each of our panelists for a lightning round of introductions. And while I'm doing that, I do invite you as participants to also take a moment and introduce yourself in the chat if you haven't done so already. So first we have Amber Haltink. She's the commander with the Renfrew County Community Paramedicine Program. Amber, I invite you to unmute yourself and introduce yourself.
Great, thanks, Maria. My name is Amber Haltink. I am the commander of community programs in the County of Renfrew Paramedic Service, which oversees our community paramedicine program. I've been in this role for a few years now, but involved with community paramedicine since 2008. I would like to acknowledge on behalf of the County of Renfrew that we are meeting on the traditional, unsurrendered, unceded territory of the Anishinaabe Algonquin people. We would like to thank the Algonquin people and express our respect and support for their rich history, and we are extremely grateful for their many and continued displays of friendship. Looking forward to chatting today with the other panelists about raising the profile of all the great work community paramedicine has played, especially during the COVID-19 pandemic.
Thanks so much, Amber. Had a sticky mute button there. Thanks for joining us. And next we have Tin Lunn. Tin is a project coordinator at Covenant Health Palliative Institute, and she leads Alberta Palliative Care Competencies and Education Grant Initiative. She's also served for 18 years on the front line as a paramedic, and I'll invite you to unmute yourself and introduce yourself now.
Hi there. So my name is Tyne. I am tuning in today and visiting with you from northwestern Alberta. So I'm coming in from Treaty 8 territory, which is the traditional unceded lands of the Cree, the Slavey, the Beaver, and the Chippewa peoples. I always like to reflect and love that we can collaborate across the country and learn about the lands, and just wanted to take a moment to give thanks to the ancestors and the traditional stewards of the land, because without our connection to the land itself and all our relations, we would not be enabled to do all of the work and cooperation that we do together. So my current role, thank you, Maria, is coordinating and leading a project with the Palliative Institute for provincial education for generalist and specialist health professional education. But just prior to that, I have a pretty diverse multi-care setting and practice setting paramedicine experiences, and most recently throughout all the years of the pandemic was working full-time directly as a frontline community paramedic up in the remote rural areas of the province. So I am glad to be welcoming my colleagues across the country here and hoping to bring some perspective from that point of view. Thank you.
Thanks so much, and thanks for joining us. Next, I'd like to introduce and welcome Matthew Crossman. He's the Vice President of Operations at Medavie Health Services. Matthew, over to you to unmute yourself and introduce yourself.
Great, thanks, Maria, and pleasure to be here. Good morning, good afternoon, depending where you're from. I'd first like to acknowledge that I'm in Nova Scotia, and I'd like to acknowledge the Mi'kmaq Key and the ancestral and unceded territory of the Mi'kmaq people. Very excited to be here today. I've been paramedicine for over 22 years and had the great fortune to work throughout the country and down into the US as well. Currently responsible for our operations in Prince Edward Island, Ontario, Alberta, Saskatchewan, Manitoba, and also our federal business. And we Medavie is a not-for-profit organization that has three main branches. One is Medavie Health, where I have the great fortune of working today. We also have Medavie Blue Cross, which is our insurance business, and then the Medavie Health Foundation, where all of our dividends and profit go to, that's then reinvested back into the into the areas that we're providing service. Medavie provides paramedic services, home care, mental health, dispatch services, 811, telehealth, and a wide arrangement of other services. So really excited to be here today because community paramedicine has really evolved and grown over the last number of decades. In my career, I've seen such a tremendous uptake on the support and provision that community paramedicine can provide to the communities. And we all know that healthcare is changing and becoming more and more challenging. So it's important that we come up with new solutions and work together to try and find initiatives that we can build on and move forward. So thank you and appreciate the opportunity.
Thanks so much, and thanks for joining us. And now I'd like to introduce Marty Mako, Commander of Mobile Integrated Health at Niagara Emergency Medical Services here in Ontario. Over to you for further introduction.
Thank you, Maria. I'm here today from the Niagara region, and the nations that do share territory lands in present-day Niagara include the Mississaugas of the Credit First Nation, Six Nations of the Grand River First Nation, and the Haudenosaunee Confederacy. Present day, we are made up of 12 municipalities, a mix of rural and urban, population of about 430,000 people, and the unique geography includes us being surrounded on water by three sides. So we have Lake Ontario to the north, Lake Erie to the south, the Niagara River to the east, and also an international border with New York State. So unique challenges that presents. Specifically to my portfolio, the commander of mobile integrated health. I find the terminology in this space interesting because we use community paramedicine, we use mobile integrated health, and just a quick explanation of what we include in our MIH program area, which I am overseeing. It also includes our community paramedicine teams, which focus on the proactive work with trying to reduce ED visits and all of the other great work that CP does, but it also includes some multidisciplinary response teams that work in the 911 environment. So we have a mental health response team that pairs up a paramedic with a mental health nurse that respond in real time to low acuity mental health and addictions calls. We have a falls intervention team, which involves a paramedic and occupational therapist responding together to low acuity falls. And we also have teams that focus on homelessness and other specific patient cohorts. So it's an integrated model of proactive and reactive together. So that's the unique aspect of mobile integrated health, which I'm happy to expand on during this talk. And why I was excited and interested to sit on this panel today is just the diversity of CP programs across the country. As the saying goes, if you've seen one CP program, you've seen one CP program. There's so much diversity within this landscape, and I'm excited to learn from everyone else today.
Thanks so much, Marty, and all of our panelists for joining us. And just before we dive into that discussion and the opportunity to hear about and learn more about, what community paramedicine and different programs are called and what they look like, and really, how they're set up and structured and responding in different and important ways. I want to begin by thanking each of you for the ways that you've been responding and working to meet the health and social needs of people during an ongoing pandemic over the past few years. So a huge thanks to each of you and to your teams. And thanks for joining us today to share your experiences and your thoughts to help us shape the future as we move through the pandemic and we look forwards to think about how do we set up, as you said, Marty, in different ways to respond to people's needs at home and closer to home and in community, both in a proactive and responsive, reactive sometimes way. So let's start with our first question. For the panel. I have a few questions for the panel. I also invite you to share questions you may have for those joining us from across the country using the question and answer feature in Zoom, and we'll look for opportunities to bring those questions into the conversation as well. So the first question, and Marty, maybe I'll start with you and then we'll go around our virtual circle here, is can you share a little bit with us about what community paramedicine looked like before COVID? And how it's changed during COVID. And then looking forward to what might be next. How do we continue to build on the positive changes and successes as we look forward and prepare for future care closer to home, but also future crises?
Yes, thank you. Great question. I'll give you a little bit of a history. This is speaking to Niagara's experience. As I mentioned, if you've seen one program, you've seen one program. It started 10 years ago in Niagara. This is actually our 10-year anniversary of community paramedicine in Niagara. And it started in our most rural municipality known as Wainfleet. So the issue or the challenge there that we were presented with is very low 911 call volume. So it didn't make a lot of sense to situate an ambulance base for literally one 911 call a day that they would be responding to. So CP in that municipality served as a capacity enhancer, where we had a community or a paramedic at the time sitting there, but only responding to about one call a day, one call every day and a half. How they were able to fulfill the rest of their day was by performing proactive home visits, which was also much needed in that community due to the access barriers of living in a rural municipality. So that's how CP actually started for us, was in one of our most rural municipalities to enhance the capacity of a paramedic. Their primary response is still 911 calls. So if they're in the midst of a home visit and a call, priority one comes in, they do have to leave, and because they would be the first responder on scene as an ambulance is coming from the next closest base, which could be up to 30 minutes away. So that was how the eligibility criteria in that program is strictly geography and where you live. So they didn't have the same parameters of needing to be a high user or ED diversion. It was really based on geography. So that was our first program. And the other one we had in existence prior to the pandemic was a high user program. So this was fully funded by the Ministry of Health in Ontario, and the focus was on individuals who had a minimum of 5 ED visits or 911 calls within the past calendar year. And these are individuals often with chronic physical health conditions. So you're talking about those with diabetes, COPD, CHF, hypertension, where their exacerbations often led to frequent ED visits. So by having a community paramedic program, we were able to do intake visits, roster, and proactively visit these folks to be able to prevent those exacerbations from the chronic physical health conditions. So that's what CP looked like for us prior to COVID. During COVID, there was a significant growth in funding and opportunity available. The biggest one came to us through the Ministry of Long-Term Care, and this was called CPLTC. So that stands for Community Paramedicine for Long-Term Care. And the new patient cohort here was individuals, seniors, who are either on the wait list for long-term care currently or on the trajectory for admission to long-term care. And I think it was due to COVID, the real spotlight on long-term care and the problems with that sector showed that CP could be an opportunity to keep these seniors safe and healthy at home longer while they're waiting for admission to long-term care. So that was a significant growth opportunity. And the one other one I'll highlight is focusing on homelessness. We were also given temporary funding to create a street outreach community paramedic team. And this is the cohort that are often not accessing healthcare due to these barriers and how they're treated, quite frankly, when they do come to the hospital sector for care. So they're often deteriorating out on the streets, living vulnerably. And so we now build trust and relationships by proactively visiting them in encampments where they're living rough. And so this was also temporary funding we received. So yeah, quite growth during COVID. And it was often in those patient cohorts we had not been serving directly previously, but their challenges were exacerbated by the pandemic.
Thanks so much, Marty. Maybe moving from what you shared happening in Southern Ontario to Eastern Ontario, I'll invite Amber into the conversation.
Yeah, so we had a similar trajectory of our program. It was initially grassroots driven back in the early to mid 2000s by paramedics that would go out and respond to 911 calls and see generally an older population, frail, with difficult access. And these paramedics would then go and return to these patients' homes post transport to hospital to do some follow-up, things like, where are your prescriptions? You have some falls risks in the home. You have no food in the fridge. You heat with wood, and it's winter and you have a broken rib now. So how are you going to get the wood from the outside to the inside? So it actually was spearheaded by paramedics, and then it was more formalized. Going back to our roots, sort of, we had a small pilot project in the northern part of our county, which mimics what is the current day CPLTC program that we have funded. So we targeted a wait list of 32 seniors that were on the long-term care wait list for a local long-term care facility, and partnered with them, the long-term care home, to provide PSW support. And we were the medical clinical support for these folks in the home. Fast forward to the pandemic, similar to Marty, our program tripled in size literally overnight. So we've had some challenges just in terms of responding to that, but we were able to muster up enough staff, and we've been hiring continuously, as I think has been everyone else in the healthcare sector. So we too are part of the CPLTC funding. That funding has definitely accelerated program change, that we've been able to better respond to the needs of those in our community. Traditionally, it was the older population. In Renfrew County, we do have an older population in comparison to the rest of the province, so we're a little bit ahead of the curve. But we were also seeing a lot of younger folks and going in and supporting long-term care homes that were on outbreak. We were supporting the community in terms of vaccination for COVID, mass vaccination clinics. Our health unit was very small and is very small. We were supporting with doing the majority and at one point just all of the testing for COVID across the county. So our county is quite large. Paramedics are mobile. Paramedics are well situated to stand up, and we have the logistical support to provide those supports to the community. So it's been a real change, but the crisis has also been a massive opportunity to shed a bit of light on the great work that community paramedicine can play within the system.
Thanks, Amber. And then moving out west, Tyne, I'll invite you into this conversation area, your experiences and also your thoughts for the looking forward.
Sure. So just a clarifying point, though, my name tag banner here reflects my current role. The experiences and the perspective I'll bring to this conversation comes from Alberta's provincial EMS system. So in a similar way, Marty touched on the terminology. Our program out west here in Alberta throughout the entire province is called the Alberta Health Services EMS Mobile Integrated Healthcare Program. And in terms of kind of the what was it like before, reflective to ongoing throughout the pandemic, some of the changes, we're really uniquely situated that because we have the high value of already being an established provincial paramedicine program within the provincial healthcare organization. The way we didn't have many pieces that changed our structure. We actually already, when crisis teams and command centers were set up and were strategizing how to urgently and rapidly respond, and they were asking the questions of who can we get to go do community testing? Who can we get to go deliver this? We were already there with capacity, with the training, with the skill set at the ready. So we were a really valuable lever for a lot of those other integrated care teams and leaders to reach for and delegate off to us, and we rose and met those challenges. So that was reflective in our rapid ability to have capacity to perform community testing, to increase our capacity for assessments that we were already doing across different communities and organizations, but they could become more focused on targeting COVID care, and then different ways that our program was able to already use our existing structures and reach to then do outreach and care for the more marginalized or structurally oppressed sectors like the houseless populations and the immobile, seniors and others with that way. So the kind of the bones and the foundation of our program really fortunately was already in place. And then we just kind of kept adapting to the different needs and the different asks. And as that went on, it was very rapidly reflected back at the capabilities and the capacity of community paramedics and our collaboration across the province to be a real key integrated health team for the response.
Thanks so much, Tyne. And over to you, Matthew. You have the look across several provinces and regions. What did it look like before? How has it changed? And where do you see the opportunities going forward?
Yeah, thanks, Maria. And very similar to my colleagues, fantastic stories of growth and potential. We started out in lots of different areas where we would find a specific need in an area. Oftentimes it was rural areas, as some of my colleagues mentioned before, where they needed some type of provision of service. So we would develop programs such as falls prevention, senior check-in, complex patients, things like that. But what we found is it quickly metamorphed and the need began to grow, and we started to get more and more asked. So some of our programs across the country have kind of metamorphed into remote patient monitoring, palliative care, extended care, paramedic programs, which is essentially some of my colleagues talked about doing visits to long-term care centers. We've had one program in Nova Scotia and Saskatchewan that's been in operation for about 7 years now. About 90% of those patients are being able to be treated and released on the scene. They're not transported to hospital, which is a tremendous savings, not only to the healthcare system, but also to the long-term care centers as well. And then we've also started to tackle some other things like ED discharge, ALC wait lists, looking at what are some of the needs in the healthcare system and how can we kind of meet those needs. As one of my colleagues, Marty, mentioned, look at one program, it's one program. They are very much different across the spectrum of each province. When COVID-19 happened, just like my other colleagues, we were very fortunate to have some of the infrastructure and some of the resources already in place. So we were asked very quickly to be able to pivot, and we pivoted to things like mass vaccination clinics. GoVax in Ontario is a good example where we've been providing 8 buses a day to do mass vaccinations in the Greater Toronto area. We've also partnered with the Indigenous Services Canada, so we've started to do primary care placements in Northern Ontario, Manitoba, and Saskatchewan, where paramedics were flown into remote areas to be able to work as a multidisciplinary team with doctors and nurses to be able to provide care during the pandemic to some of those harder hit areas that maybe aren't able to get some of the staffing. And we've also been able to develop things like our prompt teams, which is a multidisciplinary team staff with nurses, paramedics, physicians, pharmacists, project managers, et cetera, to be able to deal with mass outbreaks. So for instance, if there's a long-term care center that becomes infected, including the staff, we're able to deploy a team and send them in to care for those patients, but also for the providers and work until they're actually able to take back over operations of those centers. So those has been some very impactful programs, which we've been able to see a lot of great success. Just as we look to the future, one of the things we've started to see a lot of is a lot of mental health support and a lot of mental health need, not only just in the community, but also for practitioners as well. So I think as we start to look forward to some of the different programs and some of the changes we might see, I can see a little bit more need in that space, and we're starting to see some potential opportunities for our staff to do more and be able to work a little tighter with those interdisciplinary teams.
Thanks so much, everyone. And so maybe picking up on that reflection, Matthew, in terms of the change in the needs for mental health care and services you're seeing both in the calls coming in and in practitioners and providers. Just invite others to add where you've seen that change and how you're responding in different ways now. And as we all know, I think importantly that we continue to do so going forward. So invite you to share reflections on the changes that you may be making or you see opportunities to continue to shape going forwards. And Amber, maybe I'll start with you and then over to Tyne.
Sure. Yeah, we're certainly seeing an increase in mental health calls, both on the 911 side, but also more complex mental health patients within our community paramedic program. So referrals that we historically would not get, we're now receiving more and more referrals to help support these folks and do some of that system navigation piece. I think a key next step for our organization is to further integrate and really collaborate more effectively than what we are now with community mental health. Part of the barrier is just health human resources. And I think they are completely strapped for support. And that's an area that paramedics, again, can help bridge that gap. And we're often the only point of contact with a healthcare practitioner in these patients' lives. And so I think, areas of growth for us would be continued education for paramedics and community paramedics. We have great training and education in response to the mental health crisis situations. But also, I think we need to do a little bit deeper dive into more the chronic mental health and how to better support those folks. But linking up the system navigation piece is something that community paramedicine has been pivotal in linking up patients with other providers and organizations within their communities. And as Marty said, you've seen one community paramedic program, you've seen one. I think that is, speaks to the strength of the programs because they are responsive to the needs of the communities that they serve. In Renfrew County, we don't have a large population that is experiencing homelessness, but we do have, a large, vulnerable population in terms of aging seniors, no public transportation, lack of primary care. And one of the pieces that we stood up for that was our virtual triage and assessment center. And so that's a virtual access to primary care. And through that, we also have a link to mental health services for folks who either can't get a hold of their primary care provider or they don't have one. So we're sitting around 30% of unattached patients of our population that don't have access to primary care. So using those pieces and building those partnerships and being innovative about our thought process around the health system, it's changing and we need to be able to adapt with that change.
Thanks so much, Amber. And sounds like so much of that, as you said, responsiveness and change and adaptation underway. Tyne, over to you and how you're seeing the response and evolution and opportunities and needs going forwards.
Yeah, so a lot of similarities to echo what Amber was saying. The mental health problems and the increasing and escalating mental health struggles of our population, they were not new from the pandemic, but what the pandemic really did was exacerbate and worsen existing. And then where community paramedics are very uniquely situated in the health system, we tend to have a unique lens kind of in all the cracks and all the holes. We really get called into and have a way to intersect in those spaces. So Amber described it really well. A function that we tend to do really well is we can come in and we can identify and we can serve as connectors. And so with our program, there are definite inequities that exist between urban and rural in terms of access to resources. And a hard experience is recognizing the need and seeing the need for those persons that we're getting called to, and not necessarily being able to turn around and have local resources or capacity ourselves, but really doing the very best with what we have at the time with the integrated care teams. So in our more urban centers, similar to some of the programming Marty described, we have some core teams where community paramedics partner with mental health professionals and will respond and be able to go either provide some assessment and some care and connect to some supports within community, or we'll be able to provide and get them connected into resources that are better suited than having people just going to an emergency department. We all know that emergency departments are one of the worst places that somebody needing mental health support can go to, but it's often an only resource. So in that way, we have support from the mental health colleagues, and then we can also sometimes be supporting our regular operational paramedics that way, where if they're getting called to some of the people with a really focused mental health need, sometimes we can help to navigate and connect them into better resources that way. The other piece is my experience really working up in kind of northwestern remote rural is, kind of to shift the conversation is we were able to recognize quite a languishing experience of the health professionals themselves. So not just within our own teams and our colleagues, but many of the long-term care settings, the supportive living settings, the emergency departments, the acute care facilities. There was very much an identifiable need just for that peer support and that collaboration where, people were always showing up and doing their very best. And that very best looked different on different days. And so sometimes community paramedics could function as, sometimes we can just be that fresh set of eyes with some different ideas and some different solutions, and to help not only be advocates for the patients, but we can actually sometimes help with advocating and connecting health professionals who have, maybe been knocking on certain doors of other allied professionals and haven't got a pathway in. Sometimes when we come in, we maybe have some pre-existing relationships that we can leverage. And so really that whole scan of, where we are working with scarcity and under-resourced areas, how can we really do the very best to the full scope with the different allied health teams? And that was it's out of an unfortunate necessity, but it ended up being a real silver lining, is seeing the increased capacity of the teamwork in that way.
Thanks very much, Tyne. And Marty, maybe I could invite you, building on what we've heard so far, to share some new specifics or concrete or in a lived or living experience of what it might look like to be connecting with mental health colleagues or other resources in your area.
Certainly. As we're presented with these new challenges, one of the things I love about community paramedicine is our ability to be flexible and adaptable to change. However, we're also trying to avoid overlap and duplication of service delivery with other community partners, because mental health is not a new space. There's lots of service providers already there, and they've been doing great work for a really long time. So we're trying to really fill unique gaps and meet unique needs while working together. So the key for us has been partnership and collaboration with other agencies who are already speaking to mental health specifically, working in that space. Because of the challenge we were presented with, and this started before the pandemic, was a significant increase in mental health 911 calls And our only response was an ambulance and 2 paramedics picking you up and bringing you to hospital. So I don't care what type of ice cream you like, you're getting vanilla. That was the only option that we had available when they needed a different type of ice cream to meet their needs. It's about getting patients the right care at the right place at the right time, not just the fastest care. That's not always needed. So what we did was formed a team called MHEART. So it's called the Mental Health and Addictions Response Team. So we pair up a paramedic with a mental health nurse who is donated in kind from one of those organizations that already specializes in mental health. Because what we acknowledged was we don't have that subject matter expertise in-house, but we know we need it. So instead of trying to upskill our own staff, we brought in someone who already has that expertise, and now we respond together. So the paramedic, when they respond to a 911 call, does their basic assessment first to ensure hospital transport is not required. And if it is, we do bring in an ambulance for transport. But if we decide through our assessment it's not, and the patient signs a refusal, then we have the mental health nurse right there on scene in real time to do some care planning, to look at what type of referrals would be most appropriate in the community to help with that system navigation and better support to hopefully prevent the next call. So maybe we didn't prevent this 911 call, but can we break that chain for those frequent flyers to try and get them connected to the right supports and services they need for the future? Because oftentimes it becomes a rotating door where we bring them to hospital, they're discharged back out to the community and back again, when the reason for that is they're not getting the care they really need, and they're not getting connected to those services they need. So that's the benefit for us that we found of having the mental health nurse there in real time when the person is more open to perhaps a change and linking to a different type of agency. So the beauty of that partnership is that we work together. EMS provides the paramedic in the vehicle. We have a number of community agencies that chip in the mental health nurse, and then we work together. And that's what our model looks like in Niagara region.
No, that's thanks so much. Really, concretely, and it sounds like quite a diversity of partnerships, and really depending on that partner organization and the in-kind support and people they're able to connect you with. It's really encouraging, though. Matthew, anything you'd like to add in terms of how you've been evolving and how responding to mental health and or addictions calls are looking different, the calls, and also in supporting the workforce?
Yeah, I think you touched a great point, Maria. Obviously, first and foremost, our staff safety and well-being and health is paramount to our success and everyone's successful. I think we, as an organization, have invested a lot into the well-being of our staff and continuing to make sure that we have programs in place for support. And I think we're going to continue to do that. I know we're going to continue to do that and look for new ways to be able to even invest more and provide them even more supports. We're definitely seeing a shift and an increase in mental health calls. Much like my colleagues, we've stood up some programs as well. We have a couple of different programs. One program, we have mental health practitioners, masters of social workers, and RNs with psychologists and teams integrated with psychiatry care who are providing service alongside paramedics and other health professionals. What we found in those programs, so we have a couple of different models. One is a 24-hour access line, and then others with mobile teams that are able to go out. So a caller is able to call and essentially be assessed, and then from there they're able to either be treated and released, or a mobile team's able to respond and be able to go see the patients. What we found in these programs has been that about 85% of the calls are being able to be handled over the phone, which is great. And I think technology is something we need to leverage and look at more, specifically with COVID-19 over the last couple of years. We've seen a lot of different accelerated programs using technology, remote patient monitoring, other types of devices. I think that's even more important and paramount as you start to look at the health human resource shortages across the country. It's not unique to one geographic location. It seems to be everywhere. So I think we need to start to utilize technology so then we can better utilize our resources for people that really need it. What we've really seen, though, is that we've seen a big reduction in these programs to police and EMS. So by putting the right practitioners in front of those patients, we're able to treat and release them and keep them happier and healthier, which I think is really important. Another thing that's really paramount is kind of, I think Marty mentioned, we don't want to duplicate services. There's already lots of programs out there, so it doesn't do anybody any good to have the same service. What we need to do is look at where is there a lack of service, or where is there somewhere that we can bridge. And a program that we've developed out west in Saskatchewan that's been tremendously successful over the last year, we've created a community paramedic program specifically around detox. There was a long wait list for patients who are suffering from mental health and addictions. And we were able to put together kind of an interdisciplinary team where our team members are able to go out, respond to individuals' residents or areas of place where they live, and we're able to detox them, we're able to prescribe, we're able to administer medication. We're able to fully link with psychiatric care. And the few thousand patients that we've seen in the first year has been tremendously successful. One, because we're building personal relationships and we understand those patients. I think one of my other colleagues, Time, mentioned that it's really important to kind of put the patient at the center, break down all the barriers, whatever that patient needs, get those patients the resources that they need, not just what's in our existing program, but really break down some of those barriers and get them the resources they need. Oftentimes the system can be very confusing. I've worked in healthcare pretty much all my adult life, and even I find it confusing sometimes where to access things. So for the layperson who really doesn't understand, sometimes system navigation can be one of the most complex aspects. So having a resource hub or a navigation center that can actually get the patient the right resources, I think is very paramount as we start to move forward. And it's only becoming more and more complex.
Thanks so much, Matthew. I just want to pull in and respond to a question that Diane from BC has posed to our panel. You'll see it in the chat, and it's the question of how do we break the chain of requiring patients to sign a refusal of transport when treat and refer or treat in place with an integrated team is the best option for the person. Amber,
I saw that question. Oh, sorry.
No.
Yeah, I was going to jump in. I was
go for it, Tyne, and then I'll pass to Amber.
Good. Yeah. So it's a great question, Diane. And you just, really echoed what Matthew was saying about, the right care for the person in place, and that transport isn't always the case. So that piece is something that our teams across the province are working on at the moment. So we don't have 100% answer because we're trying out to see what works. But what we have right now is we have some protocol pathways built in between our regular 911 operational paramedics, where when they get called to any of the supportive living facilities that already have some healthcare staff on site, they have the agency, if they go there and they recognize that it's the nature of the call is something that could wait or something that isn't best met by transport to the ER and could be managed by the community paramedics, they can actually hand off. And so sometimes, and that's facilitated through our coordinators and through overseeing either the facility physicians or we have access to some provincial physicians who can guide and help us build up care plans. And sometimes that looks like community paramedics being able to come over right away and hand over care. And sometimes it means that there's a bit of a gap between the community paramedics freeing up and going there later that day or following up the next day. But a key piece in that is making sure that if we are transitioning and handing over, we're doing it in a safe way. We're making sure that they're getting good care and good assessment and follow up in the interim. But the crews tend to be really good at recognizing when, this is a pre-existing chronic condition. It might have gotten worse today or this week, and it's something that probably could be managed more effectively in the home. That's going to improve the outcomes for that patient. It's going to improve cost savings for the health system overall. And it's just the best care at the right place at the right time. So right now that isn't expanded to pathways in individual homes, but that's something that our overall operational and mobile integrated healthcare physicians are looking at how we can safely do that and bridge those pathways. Just so that there's more decision-making and more recognition that not everybody needs to go to the ED, and paramedics right there at the scene are going to have different resources and physicians to call and have the supports to build a safe care plan in place.
Thanks so much. That sounds like it's a very timely question and work underway to address. Amber, over to you.
It's similar in Ontario. So we have a base hospital system. So paramedics are not self-regulated in Ontario. Our community paramedic program does have a medical director that is separate from the regional base hospital, but the base hospital program is piloting through the Ministry of Health some treat and refer pathways. And so one of those would be for palliative care. So, I think that there's some legislative changes and some regulatory changes that need to be made in order to have that, be broadened, but work is underway, and they are evaluating that in terms of, quality improvement to provide the best care to the patients, which isn't always an emergency room. It's tricky in a geography of Renfrew County where we only have emergency rooms, and most of them are small rural emergency rooms. We have no walk-in clinics. So hauling these people off to a small local emergency room where they only have 6 beds is not always the answer. So we're working, as Tyne said, with treat and release. We're also looking to, patients that are refusing treatment, we can also follow up with a community paramedic visit. And then the community paramedics are also well positioned to link up these patients with other resources that are readily available in the community. So it's similar approach. And I think that, there's some system change that is in the works, but these things do take time.
Thanks, Amber. Matthew, anything you wanted to add in responding to that question?
Yeah, just a couple of points. So very similar to my colleagues, I think regulation or depending what province you're in, it's normally a regulation change that needs to occur, legislative change. But there is work that's already underway in most provinces on this. The other thing is that we're also starting to see, and I know we've got a couple of programs, we're looking at secondary triage. So we're really building the interdisciplinary team. So taking everything from home care, mental health and addictions, paramedic services, acute care, primary care, and really building pathways for those patients. So a couple of programs that we have in place, one is it works both ways, I should say. So we have a program which has our ED discharge. So patients who would respond to an emerge department. Otherwise, the physician's not sure what to do with them. They would have to admit them to the hospital for observation. We've developed some pathways where we're able to put remote patient monitoring through our communication center and through our mobile integrated health or community paramedic programs. We're able to then send out practitioners to the home. So they're able to discharge people from the home. The same works for our NOBIs, which is essentially our non-transports. Oftentimes, we just want to make sure that the patients are happy, healthy, and safe and supposed to be discharged at home. And we do 100% audit of all of our non-transports. So 100% of our non-transports, we actually audit to make sure that it is appropriate that the patient did stay home and that they weren't transported to the hospital, because that's never a good thing if they should have been transported. But just working together, I think, is key to kind of build and change those legislative changes.
Thanks so much. And another question has come in through our chat feature from Susan. I think it's for you, Matthew, given what you shared earlier. And that says, does the Saskatchewan detox program or care at home require long-term follow-up with patients, or are they transferred to other care agencies?
Yeah, great question. So a little bit of both. So if I use the first year statistics, we had about 2,000 patients with our one program that those practitioners were able to carry throughout the year. Some of them required longer caseload than others, but about 1/4 of all those patients were transferred to other programs. So other mental health and addictions programs, for instance, some needed longer treatment, some needed in-person or in placement treatment, but we were able to also avoid about 500 ED and hospital admissions. So when you look at the numbers, it was pretty staggering and pretty positive to the health agency that otherwise those patients would have been admitted to the hospital. So again, it's just building the pathways and making sure. Why this program came to fruition was essentially it was about a 60 to 69 day wait list. So for anyone who was looking to get into a program, it was a very elongated wait list. What we found is by wrapping these services around the patients, we had a pretty big success rate, and the patients who did relapse were much quicker to come back into the program and begin healthy living, which is really great.
Thanks so much, Matthew. Our time is flying by. Really appreciating this rich discussion, and there's more questions coming in. So I'm going to try and create an opportunity to respond, at least to hear from a few panelists for the next couple of questions in our last 10 minutes or so together. So there was a question earlier, and I think many of us have reflected and seen the role that technology and that rapid change to more virtual care that has happened across the country during the pandemic. So in your experiences, and maybe Amber and Tyne, I'll turn to the two of you. Where have you seen technology be really helpful in community paramedicine, and where there's been limited technology, perhaps in more remote communities? Have you seen opportunities to work in different ways? So it's really anything you'd like to share in terms of the role that technology can have in leveraging connection to services. So Amber and then Tyne.
Thanks, Maria. So technology has been our friend in terms of infection prevention and control. Trying to keep our staff safe. So we did touch on that earlier. We've stood up in partnership with various hospitals and Ontario Health, the virtual triage and assessment center. So I did speak briefly about that earlier, but that's having virtual primary care, just a phone call away on a 1-800 number. And those physicians or nurse practitioners work directly with community paramedics, and it is a bidirectional relationship. So community paramedics can also liaise with the VTAC physicians. Whenever somebody calls in and they might need a physical assessment or they might need some point of care testing, we can send a community paramedic out, and then they work in conjunction with that VTAC physician. They do the assessment, they do the diagnostics, they do the follow-up, they can help start treatment in the home, and that care is really wrapped around patients. So whenever the patients can't get to see a physician in person, a lot of physicians' offices were closed during COVID. Community paramedics were leveraged to act as an extension of primary care. We certainly did a lot of virtual visits, telephone, landline. So in Renfrew County, there are pockets where there is no Wi-Fi, there is no cell coverage. So the good old telephone worked quite well, and we were able to do a lot of assessments. And I think one of my colleagues did share earlier about the relationship piece. Paramedics establish these relationships with patients, which is key because they're able to pick up on some of the nuances in the conversation. And these patients are often pretty open with us about what's going on. And if a visit was truly required, we would go out. We also partnered with a lot of family health teams and organizations to help with those phone calls, because we did switch to a virtual option was preferred, especially during the first couple waves of the pandemic. Remote patient monitoring has been mentioned a couple times throughout the call. It's been great at keeping COVID positive patients home and out of the hospital. So patients that we thought could potentially have to be transported to the hospital, or maybe the physician was contemplating admission, really wanted to keep an eye on their vital signs for the COVID positive folks. We would set them up with blood pressure, temperature, heart rate, oxygen saturation. We could put in a weigh scale as well if needed, or a glucometer, and we were able to remotely monitor their vital signs. And we could walk them through the setup. We could walk them through the troubleshooting. We would be checking in with them on a regular basis. So that's been really, really great. Things like even discharge rounds with planning for these safe discharges home of patients. We're able to attend those rounds virtually. We're able to support patients for early discharge because we knew that, the hospital knew that we would be checking up on them. And again, filling that gap. Sometimes there would be a delay in home and community care getting out to see the patient. So we were able to fill that gap for the first few days or the first week. And also they were being sent home with comfort knowing that a health practitioner would be following up with them. We could set them up with remote patient monitoring, and we can do a lot of these assessments.
Thanks, Amber. Anything you'd like to add, Tyne, in terms of the role of technology?
Yeah, so many parallels and different creative pieces that Amber touched on that we're doing across our province. So I won't repeat them for the sake of time, but kind of expanding on the area she talked about where community paramedics have a function to help to bridge to discharge in a safe way, or on the other end, like Marty had mentioned, the proactiveness of keeping people from having to be admitted in the first place. A unique area that community paramedics in Alberta were able to respond and deliver care is we started delivering the medication administration of the monoclonals when they came out. So initially we were delivering the sotrovimab, and then as they advanced the research and found that the remdesivir was better suited to the advancing variants of concerns, the type of medication pivoted and changed, but we were still able to go for those people who were at high risk of severe outcomes across the province. We were able to go and set up entire hospital level care of medication infusions and monitoring and follow-up and lab work and diagnostic testing right in the home to really bridge that information to the overseeing physicians and the allied health team, and then follow up and keep an eye on that patient who for a period of time they definitely were at a higher fragility for potentially needing admission, and a lot of times being able to prevent that, and then the ultimate goal, actually connect them to the treatment that was remedying their infection and improving their actual health outcome itself. And so that has been those medications, they weren't just this one-off, they weren't just kind of like added ad hoc, they've actually been added right into our formulary. And so each of these innovations and these pieces that have come, the technology, the function of gathering arterial blood gases and different monitoring pieces, in every way that we can enhance the way that we are the eyes and ears, hands, eyes and ears of the physicians and the team on scene, better decisions can be made, more customized, focused, meaningful care plans can be made, safer care, better outcomes. And, we've had this reoccurring theme of it just increases the way that we're connecting them to the right care in the right place, instead of people either, being lost within the system or bumping into different places that aren't as functional.
Thanks so much. I see some of your colleagues nodding as well as you're sharing some of those experiences. I'm going to go to another question that's come through the chat, and I think it's a really important one. And Marty, I'll invite you to respond, and then Matthew to this question. So the question comes to us from BC, British Columbia. As you ask paramedics to do more and more, what strategies have you developed to prevent moral injury of paramedic healthcare providers? And the person posing the question says defining moral injury as the challenge of simultaneously knowing what care patients need, but being unable to provide it due to the constraints that are beyond our control.
It's really timely and interesting, because we have found, as we've tried to develop training and education for community paramedics, there's not a provincial standard in Ontario right now. So we've had to sort of cobble together our own internal training program, and a lot of the ones are very focused on the medical and that aspect of the role, not as much on the social and on those parts that you've brought up. So we've had to work together with our local college at Niagara College, to develop a training on personal professional boundary setting, for example, because now we have paramedics who are getting to know people and developing trust and relationships, which is a positive. It's needed for this work, but there's also a risk. You start bringing home clients for Thanksgiving dinner. You start bringing in pizza. There's a lot of fuzzy areas where you're trying to help, but you could be inadvertently causing some harm, both to yourself and to the patient or client. So we've had to do some training in this area to upfront proactively talk about what these boundaries, personal, professional, look like. We also have a peer support program in place. So if someone does field a difficult call, or they have a difficult home visit, they now have a peer group that they can reach out to for support, to debrief, to talk about it. How did this affect yourself? And because there's some ways we find that it affects paramedics, but they don't see it in themselves. It might be their peers that see it in them, or it could be even they go home and their spouse sees it in them. So it's really interesting work from that aspect of moral injury, specifically to the community paramedicine realm, with getting to know some of these marginalized groups who have very severe social needs. So it's not just always the medical needs that's the struggle. It's not being able to fix their food insecurity, or their homelessness, or their social isolation, their poverty. They're very tough social challenges to fix. And it's helping the community paramedic understand that it's not your job to fix that, but it's what part of it can you work on, and what part of it do you refer on to other agencies, and what do we have to accept? It's difficult, very difficult, but at least we've started having those conversations.
Yeah, thanks so much, Marty. Matthew, in a minute, anything you'd like to add to that, to a big question and conversations and work that's going to be ongoing? So recognize that, but over to you.
Just quickly, very much like Marty, we have added lots of programs for support, such as peer support, digital tools, psychiatric services, psychology, things like that, that people can access and really try and break down some of the barriers. The other thing that we've been fortunate in a few systems, we manage provincial systems, so we've got very good connectivity into the health system. One of the things that we just recently launched is a Patient Connect program for all the orphan patients for the province, and we've used this virtual technology, so it can be done virtually or face-to-face, to be able to offload some of those patients. And having some of these programs set up where we have all these different pathways can sometimes help our staff because they have the ability to refer patients in, or at least get them the help. And that's been very helpful as well, because most of the folks who get into this profession, they care very deeply and they want to be able to do really good. And it's a big challenge right now with a lot of the health human resources out there.
Thanks so much to each of you for joining our panel, for all those who have joined us from across the country to be part of this conversation, whether you were listening or asking questions, and just really struck by the conversation about how paramedics are responding to gaps in health and social needs in communities, being driven by that opportunity to be the eyes and ears, often in the home, particularly when other options aren't available, and also the data of understanding. Marty, you started us off by understanding in this community there was one call a day, so how else could we be responding? So really responding to gaps in the community and building new pathways for patients with and for patients that are taking pressure off other parts of our system as well, the ED and long-term care highlighted in particular. Encouraging to hear, and we know that there's more needed, but certainly there's system change in terms of regulation and legislation underway across the country that's needed to help excuse me, sustain and grow some of the innovations and really important changes that all of you have led and been a part of. And I think the invitation and the need as we go forward is to continue to build on the work that you've shared too, in terms of how do we support paramedics in providing care and responding to diverse and growing health and social needs. So great to hear some of those really concrete examples and new partnerships and programs already underway, and we'll be posting other links following this webinar so people can have a deeper dive and learn more about those. So thank you so much to all of you for joining. Just before you go, for folks who have a few minutes, we would greatly appreciate your feedback on this session. We have a quick poll coming up, helps us plan for future conversations and topics. The two poll questions will come up there on your screen. One is really, do you intend to share what you learned with others? And then secondly, did this webinar provide useful information? So if you could take a moment and give us some feedback, that helps us shape our programming and discussions going forwards. Once again, I'd like to thank Amber, Tyne, Matthew, and Marty so much for sharing your time with us, your experiences this morning, and in our audience for joining us. As an important topic we'll continue to return to as we focus on responding to what we know is a priority and growing need of providing care closer to home and addressing those gaps and making new connections with and for more people across the country. So thank you, everyone, and I wish you just a great rest of your day, wherever that may be, in your time zone and location across the country. Take care.